Thank you all. Thank you all for having me today to discuss yet again the risk factors for young onset colorectal cancer. For some of you who have attended in the past, I presented this data previously. I've now sort of reorganized the talk a little bit to shed some light on the risk factors, the usual suspects, and then some that we don't think about all the time. But I'm really committed to try to understand what is causing this disease so early and try to understand if there are some factors that we can think about that aren't the usual suspects. So I want to first just go through some of the typical colorectal cancer risk factors, the hypothesized mechanisms, and then talk a little bit about the literature review that I've conducted and what some of those findings can tell us. The first thing to note, and when we think about what we've heard so far this morning, and thinking about specifically Alan's story, hearing what Stacy and Susie had to say about Jessica, is this a different disease? Are we dealing with different molecular mechanisms? Is this a different molecular profile? Is it a different type of tumor? And therefore, are there different risk factors? And that's what we really need to try to understand in order to make some progress with this disease. We do know that in the younger population, because they are generally healthier before they get the disease, they have better survival. But we do know that the later stage and late poor prognosis is a real issue. So thinking about some of the risk factors, we'd like to know what these risk factors are in the younger group so that we can build upon the risk assessment we talked about all day yesterday with family history. Can we create a profile of this younger person that can help us to categorize, identify, and potentially screen earlier maybe than what we are currently doing with our earlier screening guidelines related to colorectal cancer history and advanced adenoma. So what we know already about colorectal cancer and risk factors, there are many. There are some that are modifiable, and there's some that aren't modifiable. A lot of the behavioral factors related to diet, obesity, physical activity, smoking, and alcohol, these are things that we can modify, and we know that today these account for a huge proportion of colorectal cancer, about 50%. So when we think about risk factors for early age onset colorectal cancer, the big question is, are these same risk factors pertaining to this younger group? What are some of the other environmental factors in our society? What are the other lifestyle and behavioral factors when we think about the birth cohort and the increasing incidence since 1974? If this is truly a slow-growing tumor, as it is for the adult population, that means we need to look at exposures back in 1960, maybe 1950. What was happening at that age and that stage of the US and the world? What are some of the things that were shifting during that time point? And I think that's what we need to look at, are some of these really monumental exposures that may have changed decades ago. Again, what is the timing of exposure? And what is the optimal time to intervene? When we talk about a cancer diagnosed at 17 years of age, what are we talking about in terms of interventions in grade school, elementary school, prenatally, postnatally, et cetera? We know, again, that it's not always the environment, it's not always behaviors, there's always some interaction with our predisposition or our genes that we're born with. The usual suspects, we talk about this all the time: obesity, diabetes, fast food consumption, alcohol, smoking. But when we hear stories, and we hear these a lot, young onset colorectal cancer cases are often fit individuals. They're exercisers. They played school sports. Now they're in college. Do we know if these same usual suspects apply? So we have to think about the unusual suspects. What is the role of the microbiome? We think about the exposome. This is really important. This is when we're talking about sort of the footprint of exposures throughout a lifetime. Do they happen preconception? Do they happen following childbirth? Do we see the increase in cesarean sections? Does that change our exposure to the microbiome and maybe protective effects that we're missing in these decades previous? Aspirin use in the 70s was also decreased because of risk for Reye syndrome. We know that aspirin is a protective risk factor, protective factor for colorectal cancer. Increasing incidence in sedentary behavior. Again, computer use, the technology rise in all these previous decades. People are sitting more. Recreational drug use and supplement use. Supplement use is a multi-billion dollar industry. We don't know the unintended consequences of taking high-dose supplements, high-dose vitamins and minerals, and how that impacts. They don't become antioxidants. At some point, they become pro-oxidants, especially in people with initiated tumors. So what are some of the mechanisms by which this can all occur? We know that for a lot of the behavioral factors like diet, sedentary behavior, and physical activity, a lot of these are mediated through the adiposity pathway, through body fat, through body weight and BMI. We don't know if this is the same for young onset colorectal cancer. We also know that there's an influence of hormones, metabolic dysfunction. We're going to talk about diabetes. And the inflammatory process, which is one of the etiologic factors for not only colorectal cancer, but all cancers, have some inflammatory origin. Also, decreasing vitamin D, and then we don't really fully understand the gut microbiome and what effect that could have and how that's changed over the years. When we think about all the opportunities for prevention, from the time a cell is initiated to until that cluster of initiated cells becomes something you would see on a colonoscopy, like a polyp, which is the promotion stage, and then from that going into progression to carcinoma, there are so many opportunities for prevention, but we can't prevent this cancer if we don't know what is actually impacting each of these characteristics, these stages of the disease. So let me talk a little bit about the methods of the literature review. Starting this review, I started this actually a couple years ago, and really started with the under 50 cancers for colorectal cancer. But the definition of young onset colorectal cancer is not consistent in the literature. Some studies classify people under 50 as young onset, some as under 40, some under 30. We know that this younger group is really driving the increasing incidence. Most recently, we're starting to see publications in the under 55 group, mainly for the reasons Dr. Siegel provided. Just very brief, some of the terms we use to search for these data, and finding that the studies have been conducted around the world. The majority of studies, 44% of them, were just conducted in the last 7 years. So this is a real emerging area. More people are putting their brains on this topic, which is hopefully going to help us make some headway. A little background, since we are talking about the why and we are talking about epidemiologic studies, because I'm going to go through some specific study designs. And for those of you who aren't epidemiologists in the room or not familiar with research, there's really two main arms of epidemiologic study designs. There's descriptive. There's the studies that really describe the disease, describe where it's occurring, who it's occurring to. And those are good for generating hypotheses. What Dr. Siegel showed us is how these trends are increasing, which is inspiring a lot of people to really understand why. It helps us generate hypotheses, helps us generate research questions. But once we get into the analytic side of epidemiologic studies, we're testing these questions. Now we're going to do different experiments, and we can do these using clinical trials and experimental trials where we randomize people to a placebo or a treatment. There are no young onset colorectal cancer studies that have used an experimental study design. No study has randomized young onset cases to a treatment or an intervention or a placebo or a control group. There are, however, a number of observational studies. The reason there are a number of observational studies is because this design inherently follows people over their natural sort of free-living environment. We don't control them. We don't ask them to take a pill. We don't ask them to do an intervention. We just follow them over time. And that would be a prospective cohort study. We take a cohort of people who are exposed and not exposed. We follow them forward, and we see who gets the disease, and we look at risk for disease. And we calculate a relative risk. In a case control study, still observational, but the exposure and disease has happened before we even start the study. We get all the people that we find in our population that we want to study who have young onset colorectal cancer. And then we go back and we ask them, did you drink? Did you smoke? What was your exposure to aspirin use? So we go back and ask them exposures that have already taken place years ago. And you can imagine some of the limitations with the case control study. Do people really remember what they did in high school? Do they remember what they ate last week, last year, or 5 years ago? You probably don't remember what you ate over the weekend. So there's inherent limitations with case control studies, what we call recall bias. But cohort studies where we follow people prospectively also have inherent limitations. You have to follow people for a very long time. Think about starting with a patient today. You might have to follow them for 10 or 20 years for the disease to develop. And with rare diseases, you need a lot of people in these studies, and you need to follow them for a long period of time. It's very expensive, and you lose people over time. You're sending them questionnaires every year or two. People drop out. They don't want to continue with the study. So there's a lot of inherent limitations we have to keep in mind. The other thing we have to keep in mind is that association does not equal causation. We don't use these words lightly in epidemiology. When something is causally associated, we have done our due diligence. We know there's a number and breadth of types of studies that have shown the same effect. It's not just one study that showed an effect and we make a conclusion. We look at the breadth of studies and we make judgments. We determine, is this exposure related to this disease? Can we eliminate the effects of bias, confounding, random error, or did it just happen by chance? So it's a huge, huge undertaking to really understand the literature and what the impact is. And I say this because we're going to go through a number of potential risk factors, but it's very early, very preliminary data. The quality of the exposure and outcome assessment, again, measurement error. How do we really understand how much or how well people were exercising? The heterogeneity between the study types, how different they were. The biological gradient. Is it biologically plausible that this could happen? We talk about biological plausibility. And then what is the magnitude of the effect? Was there a 20% increase associated with that exposure, or was there a 20-fold increase risk associated with that exposure? These are two very, very, very different things. So in the literature thus far, in the 157 studies that I found so far that have been published on young onset colorectal cancer, only 13 of those have really looked at risk factors. And again, these are all observational studies looking at these various areas of study. So we'll start with obesity. Now, I have to say, before I even talk about obesity, there's a big caveat in these 4 cohort studies that looked at obesity. Number one, if you look at the age range, these people were enrolled into these trials between 2 and 54 ages of disease, 2 and 54 years of age, 14 to 61, and so on. This wasn't a study to look at young onset colorectal cancer specifically, and they didn't do subgroup analyses, likely because they weren't powered to do it. There probably wasn't enough cases. So I put these up here saying that, yes, there was a positive association between obesity and colorectal cancer, and within these cohorts, there were data on these younger age groups, but we don't know for sure and can't say for certain from these data if there is a true association if we were to really identify the younger group. There were 4 case control studies looking at obesity, and again, these took all the cases, looked back at their BMI in previous years. Again, the ages for 3 of the studies included higher age ranges, and they didn't do subgroup analyses either. There was one study by Rosato et al. Who did look at the under 45 age group, but found a negative association. And again, we're talking about ways that we measure these data. One of the suggestions they make in their paper is the fact that weight loss after colorectal cancer diagnosis is quite frequent. And so when they were going back to look at exposure data, they weren't able to get reliable BMI data that they really think this is a good association or a valid association. For a number of other factors, diabetes, diet, physical activity, and occupational exposures, there were 5 case control studies. These were done in a number of geographical locations, 3 pooled studies from an Italian Swiss case control study in New Zealand, in Indianapolis, another one in Italy, and then one in LA. I underline the cases and controls because these are relatively small studies. Again, it's hard to really, with a very small sample size, be sure that the risk factors that were found in these studies are really valid and really true. We really look for the true associations. So I'm going to go through them individually very quickly. So in this study by Chen et al., looking at the specific relationship between colorectal cancers under 45 versus over 45 and their association with diabetes. In this particular study, there was no association with diabetes in the under 45 population. However, in the 45 to 65 population, there was an association that was statistically significant, about a 45% increased risk. However, we again don't know of those how many were really under the 55 or 50 age group, but perhaps there was a more significant association in the older group because they had a longer exposure to the effect of diabetes, hyperinsulinemia, metabolic dysregulation, as I showed in the hypothesized mechanisms, may be associated with young onset colorectal cancer too, and that may partially explain why you see that higher risk in the older group. Another study that looked at diabetes is the Vecchia Study. This was an integrated series of case control studies in northern Italy. No association between diabetes and colorectal cancer risk in this younger than 40 group. And then an additional study by Rosado also looked at diabetes in the under 45 population. And again, no association between colorectal cancer and diabetes for those under 45 years of age. In this study in particular, though, the large part of their data included type 1 diabetes, and that may be one of the reasons they did not find an association because some of the hyperinsulinemia factors that we know are associated were not present. And then finally, with a study with Imperial, this was the one that was done in Indianapolis. This case control study looked at individuals between 35 and 49 years of age. They had a questionnaire with numerous items, one of them being diabetes, and did not find an association in this population either. For dietary factors, the same study, Rosado, who had conducted a case control study among those under 45, found that all of these risk factors were statistically associated with decreased risk of colorectal cancer under 45. So there was a role for diet in this particular study. Again, we don't know the duration of the exposure, but we do know that these particular factors were found with decreased risk. Increased risk was more than 2 drinks per day of alcohol, and those in the highest tertile of processed meat. Alcohol is a very interesting risk factor. It's causally associated with 7 different cancers currently. And the thing with alcohol, it's ethanol is, and its metabolite, acetaldehyde, is actually a class 1 carcinogen. It's a human carcinogen. And measuring alcohol in epidemiologic studies is tough because people don't know what a serving size of alcohol is. So, sorry for all of you that had a drink last night. A glass of alcohol that people drink on average is really 1 to 2, more a serving to 2 servings. And people don't realize that the serving size is about 4 ounces. And when we talk about 2 drinks per day and when people check the box on a questionnaire, there may be some misclassification and measurement error there because people don't know what their serving sizes are, and we can't adjust for that in the studies. So this 2 drinks per day may actually be higher. But I showed in the earlier slide on usual suspects, binge drinking is increasing among young adults. So we know that alcohol and smoking is actually declining, which may mitigate some of the potential risk with young onset colorectal cancer, but binge drinking is increasing. And it's not only binge drinking, but it's actually even small amounts of alcohol. There is no recommended intake of alcohol. I know that there's a lot of data on cardiovascular disease, but that's being debunked. So currently, alcohol is not recommended for cancer prevention. Also in this study, looking at dietary factors, this same study with Imperial looked at a number of dietary factors related to calories, folate, fiber, and vitamin and mineral supplements, and no differences between cases and controls. However, in the Imperial study, this was a very small sample size. They weren't able to get a lot of the recruitment that they wanted to do. They didn't have the power to detect differences. And the time frame queried was limited 10 years prior to diagnosis for cases. and prior to the index colonoscopy for controls. So again, we don't know the exposure time frame and how that may interact with our risk. Finally, the school milk consumption in this study by Cox et al. Found that participation in school milk programs was associated with a reduced odds ratio of colorectal cancer overall, but it was not significant in the 30 to 49 age group. And this would have been great if it was significant because, what an interesting public health intervention when we already have exposure to children in schools to be able to do something that might prevent this cancer. And then finally, Peters et al. Looked at a number of dietary factors and found inverse association, again, for dietary fruits, raw vegetables, whole grain bread, for colon but not rectal cancer. Again, these subsite differences we still need to fully elucidate. And then positive associations for deep fried food, cured beef, barbecued meat. So when we see this increasing fast food consumption, this may play a role because we're seeing consistent, just in these small studies, associations with fruit and vegetable intake and meat consumption. In this particular study, no association with ethanol intake. Physical activity, the only studies that have been conducted so far in young onset are related to job-related, and there was a protective effect. And then for other occupational exposures, excess dust and exposure to wood and metal dust specifically had specific effects. Smoking, limited evidence. Not many studies have looked at this. One of the things that we're really interested in looking at is dietary patterns and lifestyle patterns. So not just looking at fruit and vegetables on their own, but looking at a whole pattern of effects. And we're going to be doing a study with the Harvard Diet and Cancer Pooling Project. We're pooling over, in this study, only about 10 or 15 studies have young onset cases, and we're going to be looking at lifestyle patterns, dietary patterns. So we put everything together in a synergistic fashion, do we see an effect? And these are some of the patterns we're going to look at. And then again, as we talked about yesterday, this precursor lesion, I was really interested in looking at, are there any young onset studies associated with the adenoma development? And we know that 30 to 40% of the population will develop an adenoma by age 60, and there's evidence that this prevalence is similar in these younger age groups. So it's an important thing to look at. So just really quick, for some of the preliminary results on adenoma, recurrence, and development, we see some of the factors in the young onset group that are less likely are aspirin use, but more likely are these smoking, red meat, and the factors related to diet. And then there's a number of other studies. I'm not going to talk about this one too much, but they looked at participants who were 31 to 54 and looked back at their history of a prudent pattern versus a Western dietary pattern and found some protective effects. Other studies have looked at women, and this is a Korean study, and found that a number of factors were associated with the 30 to 39-year-old age group. And in these last couple studies looking at current smoking and alcohol consumption, both were associated with adenoma in these younger populations. And again, I think you all have access to these slides, so I won't bore you with the details, but these trends continue in the adenoma development as well. So just as a quick summary, obesity, diabetes, dairy, dietary factors, occupational exposure, diabetes, and alcohol consumption, these are all factors that need to be further elucidated. We have a number of questions that remain relating to timing, the subsite effects, the unusual suspects, and the interaction between risk factors and looking at patterns of behavior versus individual associations. So next steps, all the good work we're going to do, and if anyone has questions, please feel free to contact me or talk to me at the conference. Thank you.